Good evening, everybody. Welcome to this subject seminar on anatomy and physiology of thyroid gland. As you know, it is one of the common surgeries that surgeons do, and it is important for us to not only know the anatomy and also know the physiology so that you can understand the thyroid physiology in terms of when to operate, when not to operate, and also the physiology that is now increasingly linked to immunology. So we should be aware that whenever the patient is hypothyroid or hyperthyroid, there it has immunologic implications, not only for the thyroid function itself, but also for the general immunology of the body. So that has now been shown increasingly by many articles that are coming up with the immunology that is linked to thyroid. So it is important to know that, and einass will talk us through these things. Over to you, einass.
Yes, sir. So like the topic is anatomy and physiology of thyroid gland. So starting with the introduction, the thyroid gland is like a butterfly-shaped gland, and it's an endocrine gland which is responsible for producing thyroid hormone calcitonin, and it is also contributing to the regulation of metabolism growth and in maintaining the serum concentrations of electrolytes such as calcium. Uh, Going ahead, it is located anteriorly in the lower part of the neck, which extends from the C5 vertebrae to T1 vertebrae. In addition, it comprises of the left and right lobe, and it is connected by the isthmus, and furthermore, it is encapsulated by the pretracheal fascia, and along with that, the internal capsule, which is the true capsule. The pretracheal fascia is the false capsule, and the internal capsule is the true capsule. And the true capsule is basically the condensation of connective tissues, and there are blood vessels which are present deeper to it. And the false capsule is the pretracheal fascia, which is the condensation, which is basically derived from the pretracheal layer of the deep cervical fascia, and it will furthermore extend to it will extend behind, and it will form the behind and forms the berry ligament behind it, and between these two zones is it's like a vascular zone which is present here.
What forms the Bell's ligament, ma? I didn't get that. What forms the Bell's ligament?
So it's like the condensation of the false capsule, which is forming the berry, like the condensation of the pretracheal fascia,
Pretracheal.
which is extending behind and forming the Berry's ligament, sir. Then going ahead here, we can see the relations of the thyroid gland, which includes anteriorly we have the strap muscles. Medially, like in front, we have the trachea, the esophagus, along with the recurrent laryngeal nerve and the superior laryngeal nerve, which will be coursing here. Posteriorly, we'll be having the cricoid cartilage, the lower thyroid cartilage, the parathyroid glands, as well as the carotid sheath and its contents. This is what are the contents of the gland. Then further going ahead with the microscopic anatomy. The thyroid gland is the main component includes the thyroid follicles. These are the smallest functional units of each gland, and basically they are the vesicular components which are lined by the epithelium. In the center is a follicular lumen, which is filled with colloid, which is responsible for the storage of thyroglobulin, which is a thyroid hormone precursor. And in addition, the epithelial cells are going to contain two cell types, which includes the thyroid epithelial cells and the C cells. Further going ahead, we have the interfollicular spaces, which will be filled with your capillaries, adipocytes, the reticular connective tissue. Then we this is what was said. Going ahead with the embryology, so thyroid gland basically is a precursor which originates from the floor of the primordial pharynx, and so it is initially it begins by arising from the first and second pharyngeal pouches of the endoderm, and it will begin. So it's basically like an outpouching growth from the primordial pharynx. It will descend inferiorly till it reaches the neck, where further it will divide into the right and left lobes, and in addition, in the beginning of the so in the third week of gestation, we have the cells which are proliferating, and a diverticulum is being created, the thyroid diverticulum, which will further go downwards through the fifth week of gestation, go caudally along the midline, and during the process of migration, the thyroid will remain attached to the tongue via the thyroglossal duct. And after the fifth week of gestation, there will be the division of the thyroid into right and left lobes. There will be further differentiation to form the parafollicular C cells. And the parafollicular C cells will be limited to the superolateral aspect of the thyroid gland. Considering the applied anatomy of in terms of embryology, we can have the thyroglossal cyst, or wherein you'll during the fifth week of gestation, normally the thyroglossal duct will obliterate and it will disappear by the 8th week of generation. But in some cases, it may persist, which will result in the formation of a thyroglossal cyst. This can sometimes get infected also and result in the formation of a thyroglossal duct cyst or a thyroglossal duct sinus. The other like an applied anatomy aspect is the development of an aberrant thyroid, wherein it can be found anywhere in the central compartment, which can include the esophagus, trachea, or the mediastinum. It could be present near the aortic arch, within the upper pericardium, or the interventricular septum as well. And the third anomaly which could occur is a lingual thyroid, because this will occur because of the failure of the thyroid anlage to descend normally, and this can result in obstructive symptoms, which could include airway obstruction or difficulty in swallowing, and these patients usually tend to develop hypothyroidism. So this is like the path of descent of the thyroid gland, and so therefore there can be various locations where the descent can get arrested, and it can result in the formation of a thyroglossal. Like if the thyroglossal duct is patent, then it could form a thyroglossal cyst or a thyroglossal duct sinus, and like lingual thyroid or aberrant thyroid. Going ahead to the shall go ahead.
Yeah. Any questions so far, Nikita, on the descent and embryology of thyroid gland?
No, sir.
Is Praveen there?
Yes, sir.
Any questions, Praveen?
No questions, sir.
Okay. I think if there are no questions, we'll Vinod, any questions?
No, sir. No, sir.
Sanya and Abdul and Sanket.
No, sir. No questions.
No, sir. No questions.
No questions.
Niranjan, any comments?
Sir, nothing, sir.
Okay, continue, ma.
Okay. So the arterial supply of the thyroid gland, it will include the superior thyroid artery, the inferior thyroid artery, and in some cases there is the presence of the thyroid einass artery. The superior thyroid artery is it's arising from the external carotid artery. The inferior thyroid artery will be derived from the thyrocervical trunk, that is like the first branch of the subclavian artery. The thyroid einass artery is an unpaired artery which will arise from the brachiocephalic trunk of the arch of the aorta. Then the superior thyroid artery will mainly be supplying the superior portions and the anterior portion of the gland and the superior parathyroid gland. Then the inferior thyroid artery is supplying the posterior aspects and the inferior parathyroid gland. The thyroid einass artery is mostly supplying the anterior surface and the isthmus.
Einass.
Going ahead with, yes, sir.
Superior parathyroid gland is supplied by?
So the superior thyroid artery is
No.
supplying the.
I think
No,
that is a good question. No,
Inferior
it isn't.
inferior
So,
thyroid artery supplies all the parathyroid glands, and inferior thyroid artery is the second branch of subclavian artery. First branch is what?
yeah. So
Supplies
like
the
this subclavian artery has three like
First
it is
part, second part, and third part.
yes sir. So
Sir,
the
it's a branch
second
of thyrocervical, sir, not a direct branch of subclavian.
No,
Correct.
no.
It's a branch
Yes,
of thyrocervical.
thyrocervical,
It's
which
not
is the
direct branch.
branch of second part of subclavian.
No, sir. It is a branch of thyrocervical. It's not a direct branch of subclavian.
Correct,
That's all.
Appa.
But
That's
what
what
is
he's
thyroid?
saying. See, the subclavian has three parts. The first part is what? What is artery from
Thyrocervical.
first part? Huh?
Thyrocervical. Vertebral.
Thyrocervical.
Correct. Vertebral artery is the first part. Second part is the thyrocervical trunk. And from thyrocervical trunk, you get the inferior thyroid artery. So, Ainas,
yes
what is
sir.
the difference? What is the difference between the superior thyroid artery and the inferior thyroid artery in terms of its approach to the gland and everything?
So like their
Is it
origins are
important?
different.
Is it important? How it enters the gland and everything? Is it important?
So like the superior thyroid artery is usually like so basically it gives two branches to the thyroid, right? Like the anterior and posterior branches,
Correct.
and
Yes.
and the inferior thyroid artery is like once it enters the fascia, like the prevertebral fascia, then it can divide into a large number of branches, sir. So like
Correct.
you have to be kept because it is closer to the recurrent laryngeal nerve. So in terms of
Correct.
ligation, you are supposed to be careful while
Correct.
ligating the inferior thyroid artery.
The Nikita.
Yes, yes, sir.
Ainas has told what is the difference between superior and inferior thyroid arteries. Can you just elaborate on that? These things are very important.
Yes, sir. While ligating, it was previously considered that superior we have to ligate close to the gland and inferior away from the gland, sir, in view of the recurrent laryngeal nerve.
Correct.
Uh,
Now, what is the current thinking?
in upper and lower poles, both the poles we are supposed to ligate as close to the gland as possible, sir.
No, I don't think so. The difference between superior and inferior is when superior enters the gland and divides into anterior and posterior branches. So if you ligate it at the apical pole close to the gland, you will be ligating both the branches. The most important thing is you have to take care that you don't damage the superior laryngeal nerve. But on the other hand, the inferior thyroid artery, as einass said very clearly, sort of branches out into multiple branches, and the recurrent laryngeal nerve can go between these branches. So the current thinking is to ligate the individual branches separately and making sure that you don't damage the recurrent laryngeal nerve.
Yes, sir.
And see the inferior thyroid artery away before it branches, and you are sure that the recurrent laryngeal nerve is away, then you can ligate it there. But the general current understanding and current teaching is to ligate the individual branches. Did you follow?
Yes, sir. Yes, sir.
Niranjan, comments?
Nothing, sir.
Okay.
Hello? Nothing, sir.
Okay, so that is the important aspect of the arterial supply to the, and as Abdul has correctly said, superior thyroid does not supply the parathyroids, because the parathyroids arise from the which arch, Nikita?
Fourth, sir.
Fourth and?
Fourth and fifth, I think, sir.
Not I think.
Third and
You
fourth.
have to definitely-
Third
Huh?
and fourth.
Third and fourth, sir.
Which is third, which is fourth?
Opposite, sir. The superior are fourth and inferior are third, sir.
Correct. So, and all of them are supplied by the inferior
Inferior.
thyroid artery. So it is not superior thyroid artery. Okay, continue, ma.
Okay. So going ahead to the venous supply, again, it includes the superior thyroid, middle thyroid, and inferior thyroid vein, where the superior thyroid and the middle thyroid are draining into the internal jugular vein, and the inferior thyroid vein will drain into the brachiocephalic veins. Then, with the lymphatic.
Wait,
Yes, sir.
wait. What is the significance of venous drainage in terms of thyroid surgery? There's only one thing which you need to know.
So, I read that if you find if at all the middle thyroid vein is found, then you are supposed to ligate that first, and then go ahead and ligate the other vessels.
Correct. See, basically, when you start the thyroid dissection, you have to look for the presence of middle thyroid vein, because as you said, it is a direct, tributary, it goes into the internal jugular.
Jugular.
So there can be quite a significant amount of bleeding if you don't identify this. So before you start dissecting and mobilizing the thyroid gland, you are supposed to look for the middle thyroid vein and ligate it. That is correct. Okay, carry on.
In the lymphatics, which include the paratracheal and the deep cervical nodes. Then going ahead with the nerve supply, so we have the vagus nerve, which is providing
No. Wait.
Yes, sir.
What you have said about lymphatic supply is not sufficient. What are the glands? What level the glands are? What are you supposed to dissect? All these things you need to say. The applied anatomy. Do you know or you don't know?
So I have not covered that part, sir.
Okay. So Vinod is going for exam. So let us hear what Vinod says. Vinod, talk about the lymphatic drainage of thyroid gland and its significance.
Yes, sir. Generally, first lymph nodes were sixth level of lymph nodes. Generally, the lymphatic drainage from the thyroid generally will be will be sixth level. So in medullary carcinoma of thyroid, there is a prophylactic removal of sixth level of lymph node, and other surgeries for the other carcinomas. There will, if the lymph nodes are positive, then we'll remove the level 6. Otherwise, we won't remove this level 6 lymph nodes.
Is it only level 6?
Hello,
Abdul?
sir?
Abdul,
Yes, sir.
what
First,
what
first
Vinod
lymph
said
node
is
will,
correct or not?
no, so first lymph node to have drained is level 6, then it can extend to 2, 3, 4.
Correct. So when you do prophylactic node dissection for medullary carcinoma, what do you remove? And when you do proper neck dissection, what do you remove?
Sir, in prophylactic, we'll remove only level 6. Sir. If level 6 are positive, then if it is left side, we'll remove the, we'll do MRND, sir, left MRND. If it is on the right side, we'll do right MRND.
For medullary carcinoma, what do you do?
If it is medullary carcinoma only in the thyroid with lymph nodes are not positive, we'll go total thyroidectomy with level 6 lymph node dissection.
Central compartment.
Yes, sir.
Central compartment nodal dissection. Yes. Will level 5 be involved in a thyroid?
Very rare, sir.
Tanya?
No, sir, usually not. It is the
What
lower
are
end of
level 5 nodes? What are level 5 nodes?
level 5
Posterior
node
triangle.
usually. Yes, supposed to triangle.
Posterior triangle, correct. So what Abdul said is right. The first group of nodes that are involved will be level 6 and subsequently it will be 2, 3, 4. So if you are doing a proper neck dissection, you will have to remove 2, 3, 4 and 6. If you are doing prophylactic alone, then you can do 6 only. Okay, now go to nerve supply.
So,
Einass.
so in terms of the nerve supply, we have the parasympathetic nerve supply, which is provided by the vagus nerve, and you have the superior, middle, and inferior cervical ganglia, which are providing the sympathetic nervous supply. In addition, the left there is the recurrent laryngeal nerves which are arising from the vagus nerve, and so basically they will they cross the aortic arch, and then they will ascend upwards into the tracheoesophageal groove. This is the course of the left recurrent laryngeal nerve, and we have the right recurrent laryngeal nerve, which will it comes across the right subclavian artery, and it will then go behind it and then ascend upwards. And
Okay.
the
What percentage is it not recurrent?
so
Huh?
so if not
You don't know.
I don't
Nikita, in what percentage of thyroids is recurrent laryngeal nerve not recurrent? Praveen? Vinod?
Sir, no idea, sir.
Come on, man. This is a very important and commonly asked question. I'm sure they taught you this in the Nikita. They taught you this in the CSEP. You've forgotten already?
Sir, sorry, sir. I got a call, sir. I didn't listen the question. Question once again, sir, please.
What percentage of recurrent laryngeal nerve is not recurrent?
It's 0.3 to 0.8%, sir. Less than 1%.
Correct. Correct. Okay, so where now we are talking about recurrent laryngeal nerve. It's very important to know. So what is the philosophy? What are the two philosophies in terms of recurrent with respect to thyroid surgery and recurrent laryngeal nerve, and which is usually followed? Abdul or Sania, please highlight this. Let them understand properly. Sania,
Can you repeat the question? I think my internet is not
what are the
stable.
two philosophies in terms of the recurrent laryngeal nerve and thyroid surgery?
So one is about identification of recurrent laryngeal nerve. It's always better to identify the recurrent laryngeal nerve and then carry on the dissection.
Okay.
Because that avoids the injury to recurrent laryngeal nerve.
Okay.
And
So how
one
do you
more,
identify recurrent laryngeal nerve? The next question.
I said it usually lies, it is like a white cord-like structure lying in the tracheoesophageal group that you can
Okay.
see going upwards and then entering, taking a medial turn to enter into the larynx.
Okay. So you tracheoesophageal groove. What are the usual landmarks apart from that tracheoesophageal groove?
So one is that tubercle of Zuckerkandl,
Correct.
where you can identify the recurrent laryngeal nerve. Otherwise,
Ah.
it's usually the tracheoesophageal groove only. If you trace it, you find it.
Okay. So that is one philosophy. What is the other philosophy?
So is it the avoiding usage of cautery close to the?
Yeah, that is a given. That has to be very very careful dissection using as minimal cautery or any other electric devices to avoid injury. There are people who say that you should not even bother looking for it. Stay away from the recurrent laryngeal nerve. But I think increasingly the philosophy is identify the nerve and ensure that you don't damage it. Niranjan?
Sir? Hello?
What do you follow in terms of recurrent laryngeal nerve in thyroid surgeries? You identify it and and preserve it and make sure you don't damage it, or you don't.
I generally tend to go close to the gland. I voluntarily don't go in searching for the recurrent laryngeal nerve. If I see it, I'll preserve it.
Okay. So I think there is still.
The teaching is you have to identify and preserve it.
Yeah. So I think the general this one is that you ensure you identify it and make sure that you don't use any electrocautery and other energy devices.
Use only bipolar.
Use bipolar and make sure that. And other thing is the other important thing which we have to do, all of us have to do, is the ligation of the inferior thyroid. So whenever you ligate the inferior thyroid, you have to ensure, because the branches can crisscross the nerve, so you can damage the nerve at various points. So you have to ensure that you identify the branches individually and make sure that you're not damaging the recurrent laryngeal nerve. So that is a most important thing. But there are surgeons who actually not bother about looking for the nerve every time. And if they are comfortable with that philosophy and if their results are good, then I don't think we can question that. So it is, and like many things, surgeons' comfort and surgeons' philosophy and surgeons' experience is very important. The final end result is that you should not damage the recurrent laryngeal nerve. That's the main thing. Okay, carry on, ma.
This is including collectively we can see all of the blood supply, which is in terms of artery. You have the superior thyroid artery and the inferior thyroid, and in terms of venous supply, the superior, middle, and thyroid vein, and the vagus nerve with the recurrent laryngeal nerve and going upwards. So then.
Okay.
Going ahead with the thyroid gland physiology.
Just a minute.
Yes.
Any clarifications, doubts, or questions or comments on the anatomy of the thyroid gland and its embryology? Any doubts? Answer, please. Yes
No,
or
sir.
no?
No, sir.
Okay.
No, sir.
Okay. Carry on.
Yes, sir. Going ahead with the physiology, we have the thyroid gland. The average daily iodine requirement is around of about 0.1 milligram. We have the stomach and the jejunum, which are responsible for absorbing iodine and converting it into iodide. And after which it enters into the bloodstream and it is uniformly distributed. And the transport of this converted iodide into the follicular cells is an ATP dependent process. Going
What are they called, ma'am? What are they called?
So
What are they called?
Sir, you have the sodium and iodide symporters, which are responsible for
Correct. Correct. That is the
the
thing.
transport, sir.
Sodium iodide is important mechanism.
Yes, sir.
Okay.
Yes, sir. With going ahead with the synthesis, first we have the thyroid stimulating hormone, which is going to bind to the TSH receptor. So basically, the thyrocytes will have one basal membrane, which is close to the close to the circulation, and you have the apical surface, which is in contact with your with the thyroid follicle. So the TSH will bind to the TSH receptors, which are usually present on the basal membrane. This will initiate the process of iodide trapping, which involves first is the increase in cyclic AMP, followed by the phosphorylation of protein kinase A, and this will result in the active transport of iodide across the basal membrane through an electric gradient towards the apical membrane. So it's basically flowing down towards the apical membrane. In addition, this is mediated by the intrinsic membrane protein, which is the sodium iodine transporter. Once it reaches the apical membrane, there will be oxidation of iodide, which is going to occur in the presence of thyroid peroxidase. Here thyroid peroxidase is mediating it, and on the thyroglobulin. Thyroglobulin is basically a glycoprotein, which is a large glycoprotein in the thyroid follicles, which has tyrosine residues which are present on this. So because of the oxidation process, this will result in the formation of monoiodotyrosine and diiodotyrosine. Further going ahead, the monoiodotyrosine and DIT, they will combine together to form T3, and DIT, two molecules of DIT will together combine to form T4. Then further going ahead, again the TSH will further stimulate the thyrocytes, which will cause basically the thyrocytes are going to form a pseudopodia, and they will engulf the thyroglobulin molecule, which is containing the T4 and T3, which are synthesized. Furthermore, there will be pinocytosis occurring, which will involve the fusion with lysosomes, and your T3, T4, and the other monoiodotyrosine and diiodotyrosines are going to be released. In the MIT and DIT will undergo deiodination, so that the iodide can be reused by the thyrocytes to they can be reused by the thyrocytes. The transport of the thyroid hormones, usually thyroid hormones are lipophilic in nature, but they have a lot of amino acids charge derivatives, because of which they cannot cross the barrier easily. Because of this reason, they will be transported through the process of facilitated diffusion through transport proteins. This includes the thyroxine. The proteins which are present includes the thyroxine binding globulin, the transthyretin, and albumin. Transthyretin is the prealbumin. Going ahead with the difference between T4 and T3. T4 is predominantly produced and released by the thyroid gland, whereas T3 is produced by peripheral deiodination in the liver, kidneys, or anterior pituitary. T4 is more potent, and T3 is relatively less potent, and it has a higher. T4 is relatively more. It has a higher circulating plasma levels in comparison to T3, and T3 is more active. The T3, as it is relatively less tightly bound to the transport proteins, it is more active in comparison to T4, which is tightly bound. and they have a different half-life with a half-life of 1 day for T3 and a half-life of 7 days for T4. Then furthermore,
just a minute. Nikita, roughly what is the percentage of T4 and T3?
It's like 70 and 30%, sir.
Praveen? Praveen, are you there? Yes or no? Don't know.
T3 80%, sir. T4 is 20%.
T4 is 20 now.
Opposite.
Correct. I think it is T4 is 80, T3 is 20, and majority of T3 will be given by conversion of T4 to T3. So the drugs that act on the for patients who are hyperthyroid, Graves' disease and toxic nodules and others where you want to make them euthyroid, the drugs that are used, they have different mechanism of actions, and the drugs that actually prevent peripheral conversion of T4 to T3 are very important. One is propylthiouracil, and others are obviously corticosteroids and
beta
the beta blockers, especially propranolol, and also amiodarone. All of these will prevent peripheral conversion of T4 to T3, because as einass has very correctly said, T4 is more potent, but T3 is more active. So by preventing the conversion, and because T3 has lesser half-life, so it will get destroyed early compared to T4, which has a longer half-life of 7 days. So all of these reasons why you should know how to control thyrotoxicosis before you operate on these patients. Where does the other thyroid hormones act? For example, thyroid drugs act. For example, carbimazole, methimazole, all of them. Where do they act?
TPOs.
You know?
Peroxide. Thyroxine peroxide.
Thyroid peroxidase. So it prevents the iodination and assimilation of iodine into the thyroglobulin. So that is where they act. The propylthiouracil also acts there, and in addition also prevents peripheral conversion of T4 to T3. So it is more effective drug. But when I spoke to Sanjay, what he said was, one, it is less available in India compared to carbimazole and methimazole. Carbimazole is slower, methimazole is much more rapidly acting, and you usually need to give 4 to 6 weeks for the thyrotoxicosis to come down. But propylthiouracil has a bit more toxicity, which is why it is less frequently used, though it is much more frequently used in the West. So these are all practical informations you need to know when you have a patient who has thyrotoxicosis and you want them to become euthyroid before you contemplate surgery. Okay, carry on, ma.
What is the proportion of T4 and
any
total
comment?
T4?
Question. Good question from Shrikant. Einass, will you take that? What is the proportion of free T4 and bound T4?
Sir, the proportion of
bound and free.
Sir, almost most of the circulating hormones are inactive, or like only a small fraction is like unbound and biologically active, sir.
What portion is that? What proportion?
Sir, around 0.5% is available. Is
too less. Nikita?
Sir, 0.3% of T3 is free, sir. And T4 is further less 0.03%, sir.
Are you sure about this?
Yes, sir.
Vinod? What is the proportion of free T3 and free T4 compared to the bound version?
Sir, 91, 10%. Sir.
Oh, that is too much. Tanya? Sanket? Sanket is there?
Yes, sir. Sir, I don't know, sir.
Tell me.
Sir, I have no idea, sir, that proportion between free T3.
Okay. Sonia.
So Nikita is right, sir. T3 only 0.3% is free. T4 only 0.03% is free. Usually they are very tightly bound.
Correct. I just wanted to see if you are. So actually, it's very minuscule amount. The active. That is why there is in patients whom you are not sure thyrotoxicosis is persisting despite you treating it. Then you do the active moiety.
Free T3.
You check for the active that is free T3 T4. Okay, continue, ma. Einass.
So going ahead, thyroid hormone regulation is mediated by the pituitary thyroid axis. It's basically like the hypothalamus pituitary thyroid axis, wherein any stimulant will cause the hypothalamus to release the thyrotropin releasing hormone. This will further go and act on the pituitary gland, and the pituitary gland will cause the release of TSH. The TSH will further act on thyroid gland, causing the release of T3 and T4. And in addition, they also this is also controlled by the negative feedback mechanism, wherein an increase in the level of T3 and T4 will cause inhibition of the release of TSH. Furthermore, T3 can also has an effect of inhibiting the release of TRH from the hypothalamus. In addition, the thyroid hormone also exhibits the phenomenon of autoregulation. It will the thyroid gland can modify its function independent of the levels of TSH. So, if there is a condition where there is a low iodide intake, then there will be preferential synthesis of T3, which will cause an increase in the efficacy. Whereas if there is an adequate or excessive iodide intake, then there will be an increase in the transport and peroxide synthesis and secretion, like the transport and synthesis secretion of the thyroid hormone will be decreased. This is what is exhibiting the mechanism of the release of T3 and T4. In addition, TSH release can also be decreased in the presence of dopamine and glucocorticoids. These are also contributing towards a negative effect of TSH release. Further going ahead with the effects of the
No, wait.
Yes, sir.
Now, so you said all this, negative feedback mechanism, the pituitary, thyroid, hypothalamus axis. So what happens
Yes,
in Graves? What happens in Graves' disease?
Sir, in Graves' disease, there is an increase in the. So basically, there's a disorder of the thyroid gland where there is a excessive production of T3, T4, which will cause a compensatory decrease in the level of TSH. Sir.
No. How is there? What is the mechanism in Graves' disease? What is the mechanism in Hashimoto's disease?
Sir, this is there is a decrease in the this is what I read, sir. That
No. I think you have not understood. We'll ask Nikita and Praveen, and then Vinod. Nikita, Praveen, volunteer.
Hello, sir.
Either of you. Vinod, you are not Nikita or Praveen, no? Wait for your turn. Either of you. Praveen? What is the mechanism of in Graves'
there
disease?
will be excess production of
Excessive?
sir in Graves' disease antibodies excessive production of antibodies to thyroglobulin, sir. This thyroglobulin causes
No, not to thyroid globulin. No. Nikita?
You're telling the opposite.
Nikita, are you there? Or she's gone to the emergency or something? Is Nikita there or not? Okay, Vinod, you answer, man.
Sir, autoantibodies against the TSH receptor, sir.
Correct. So what happens?
These are all autoantibodies are upregulators in Graves' disease. This will lead to stimulation of the TSH. So there will be active sodium import activation, and there will be synthesis of T3 and T4.
Correct. So what happens? That is beautiful. But what is the extension of what you just said?
Sorry, sir, I didn't.
See, the thing is, apart from the fact that what you said, it is actually, the antibodies, autoantibodies against the TSH receptor. So what happens is the negative feedback mechanism, which is normally will come into play, will be deactivated. So because of that, despite the fact that there is excessive T3, T4, the TSH, we should have actually, got completely deactivated and prevent further production will not happen. So it will continue to stimulate the thyroid gland to make more and more. So that the negative feedback mechanism between the pituitary, thyroid and the hypothalamus axis is lost. So that is the mechanism in Graves' disease. What about the Hashimoto's?
Here, autoantibodies against thyroglobulin and TSH receptors will be there, which downregulate.
Not TSH receptor, not TSH receptor.
Okay.
He said it, one is correct, thyroglobulin is correct. The other one is?
TPO, peroxidase.
Correct, thyroid peroxidase. So that is why thyroid peroxidase and the TSH receptor, this one, the thyroglobulin, there will be autoantibodies. So what happens is initially there will be swelling of the thyroid gland and there will be rupture of the follicles, releasing excessive T3, T4. What is called as what is the term for that? Initially, what happens? There will be hashitoxicosis. It's called hashitoxicosis. So in Hashimoto's, it is usually hypothyroidism, but initially the excessive destruction of the swelling and destruction of the gland releases the thyroid hormone, which will initially cause thyrotoxicosis, which is called as hashitoxicosis. And as the autoimmune process proceeds, there is more and more destruction of the thyroid follicles, ultimately leading to hypothyroidism. You followed?
Yes, sir.
Okay. Right. Carry on, Ma.
Yes, sir. Looking into the effects of thyroid hormones on the cardiovascular system, there will be an increased expression on the beta receptors, and which will cause an increase in the contractility, stroke volume, cardiac output, and heart rate. And the respiratory system, it will stimulate the respiratory center, causing an increase in the respiratory rate. In addition, it is going to in newborns, they stimulate the production of surfactants as well, and there is it also aids in increasing the lung perfusion with the nervous system. It look embryologically, and furthermore it will help in the brain maturation, myelin sheath formation, and axonal growth. in the musculoskeletal system, there will be bone growth by inducing the osteoblasts, chondrocytes, and there'll be or there's also, in addition, there is a synthesis and secretion of growth hormone. On the reproductive system, it helps
skeletal
in
muscle. What happens in skeletal muscle?
So there is a induction of chondrocytes, osteoblasts and osteoclasts, which will stimulate the
muscle.
Sir, the type 2 muscle fibers, the development of type 2 muscle fibers is promoted, which are like your fast muscle fibers.
Yeah, correct.
Yes, sir.
So
And
increase utilization of the sodium potassium ATPase mechanism, ATP utilization, energy production, all of that will increase. Basal metabolic rate will increase by increased muscular activity.
Yes, sir. Yeah, in metabolically looking, there'll be increase in a basal metabolic rate because of increase in the sodium potassium ATPase pump, and there'll be protein production, and in addition, there'll be increase in the glucose reabsorption, glucose oxidation, and gluconeogenesis as well. Further, going to the
what happens to the fat?
Sir,
what happens to fat?
So there is it can be depending on the metabolic status. It can either be lipolysis or liponeogenesis. Both could occur, sir.
Liposynthesis and lipolysis initially, liposynthesis also. Correct.
Yes, sir. And going to the hypothyroidism. So again, we can have primary hypothyroidism, secondary hypothyroidism, and tertiary, wherein in primary hypothyroidism, we'll have T3, T4 are not produced, because of which there is a compensatory increase in TSH. Secondary hypothyroidism is associated with decrease in the levels of TSH, which is causing a decrease in the level of T3 or T4. This is mostly associated with conditions like of pituitary disorders. And tertiary hypothyroidism is it is associated with hypothalamic disorders, wherein there's a decrease in the TRH, TSH, and T3, T4 levels, leading like decrease in TRH, which is causing a further decrease in the other levels. In terms of the clinical features, because of there is an increase in the metabolic.
This is anatomy and physiology of thyroid. Why are you including this hypothyroid, thyroidism?
So, I think we can stop here, ma.
Yeah.
Okay, sir.
Yeah, you have actually done well so far. So I think we'll ask for any questions from anybody. Sanket, are there any questions for einass?
No, so she has covered most of the things.
Tanya, Abdul?
No, sir, nothing. She's covered everything.
Nothing to add.
No, sir, nothing.
Praveen?
Sir, no, sir. Everything she
Okay. And Niranjan, your comments on how she presented and any additional information? Niranjan? Srikanth?
Very good presentation.
Sir, very good. Nice presentation.
Any comments and any additional information points?
Nothing, sir. We have covered
recognize non-recurrent laryngeal nerve, at what level you look for it?
Adan helilla, correct. What level do you look for non-recurrent laryngeal nerve? Srikanth ಹೇಳ್ಬಿಡು ನೀನೇ ಆನ್ಸರ್ ಅದಕ್ಕೆ.
ಗೊತ್ತಿಲ್ಲಪ್ಪ, ಅವ್ರು ಓದ್ಕೊಂಬರ್ಲಿ. Let them post in the, let them read.
Sanya, do you know the answer?
Just one homework.
No, I have to look up, sir. I'm not sure.
I think, I don't think I should give the answer to this age. I think what Srikanth said you should. you should look up and let us know. Okay, Shrikant, your final comments.
Very good presentation. Very good.
Einass?
Yes.
Presentation
Yes,
was
sir.
good. Again, I compliment you because you were not reading from the slides. You were able to explain, though slightly hesitant compared to the previous class. Maybe your preparation was a little less, intense. So make sure you prepare better next time. That is the only
Yes, sir.
comment. Otherwise, your slides were good, the content was good, and you were speaking, you were explaining the things without reading the slides, which is very good. That is a good habit. Please continue that. And in terms of the information that you have given is it's very relevant and very good. I don't think there's much to comment. I think whatever additional information that I wanted to give, I have given in between the as and when the topics appeared. So I think all in all, very good class. So if there are no other comments, we'll say goodbye and good night.
Thank you.
Good night, everybody. Thank you.
Thank you.
Yes, sir.